The Washington Manual of Surgery podcast is based on the 9th edition of the best-selling Washington Manual of Surgery.
This podcast is meant to condense key topics from our manual into bite-sized episodes for your convenience. Now, on to this installment of the Washington Manual of Surgery podcast.
Hello, everyone, and welcome to the Washington Manual of Surgery podcast. We bring you everything you need to know about high-yield general surgery topics built for your just-in-time learning. On this episode, we're thrilled to have Dr. Isaiah Turnbull here to review the management of common postoperative problems. Dr. Turnbull is a trauma and critical care surgeon at Washington University in St. Louis and a surgeon scientist with research focused on immune responses to sepsis and traumatic injury. He's one of my favorites to make ICU rounds with for his expertise and thoughtful insights, and I think you're about to see why. My name is Katharine Caldwell, and I'm a chief resident here at WashU and will be your host for this episode. Dr. Turnbull, glad to have you.
Oh, Dr. Caldwell, thank you. I'm really excited to be here and talk about our chapter.
Our time is limited today, so we're going to dive right in. As important as what happens in the operating room is the management of patients after the end of an operation. We know that the work doesn't end when the skin is closed, and many patients will face challenges along the path to recovery from surgery. Today, we're going to take an opportunity to talk a little bit about management of some of the more common scenarios trainees may encounter in managing a patient on the floor following an operation: hypotension, tachycardia, and fever. Let's take a patient who's been through an 8-hour lysis of adhesions and partial colectomy with primary anastomosis. The case was difficult. The patient received 2 liters of crystalloid fluid in the operating room, and the reported blood loss was 500 cc's. On the floor, the patient becomes progressively hypotensive and now has a blood pressure of 80/50. He's been receiving morphine pushes for pain control, but he's now altered and lethargic. Dr. Turnbull, how do you think about a patient who's hypotensive following surgery? What signs are you looking at that point you down one road or another? And what are your first steps in making the determination of what's going on?
So for me, the way to approach this is to think about first principles. There's really only 3 things that can cause hypotension: vasoplegia, hypovolemia, and a primary cardiogenic cause. Each of these can have underlying other causes. For example, hypovolemia can be due to dehydration from under-resuscitation or bleeding. Vasoplegia can result from anesthesia or analgesia, epidurals, or sepsis, which is less likely in the acute setting. And you can also have primary cardiogenic causes: acute CHF exacerbations from fluid overload, new cardiac processes like MI or PE. So my first step in the initial evaluation is to go to the bedside. I can't overemphasize the importance of seeing a patient who's hypotensive. And when I go to see that patient, the first thing I'm looking for are: what is my access? What are my IVs? And what is the nurse's assessment of those IVs? Are these good IVs? And can I adequately resuscitate this patient? What is my monitoring? Do I have an arterial line? Do I have a Foley catheter? Do I have an NG tube? And what are the recent interventions that have been undertaken? By the time you've seen the patient, they may have already received a fluid bolus. They may have received other medications. The next step in my initial evaluation is to look at their vital signs. What's the heart rate? Is there an art line that gives me the pulse pressure variation? Is there a measure of urine output? And then physical exam: skin temperature, pallor, and mental status. And then I'm also going to look at the surgical site. I'm going to look at the incisions, and I'm going to look, at least in this patient, in the abdomen, or for another case in another body area, I'm going to assess that site. You're really looking to make an acute decision. Does this patient need volume, vasopressors, a change in their epidural, or nothing? Is this expectant management? And then the most important question is, does this patient need a change in their level of care? These are all decisions that have to be made before you get a definitive diagnosis, but need to be made acutely to evaluate whether it's safe to keep the patient where they are.
So you've kind of made your first steps and your first assessments. As you move through your algorithm, what's kind of the next steps in workup? What's your further workup that you're moving through?
So the next thing I need to do is assess for other data. Do I have an ultrasound? Can I do a point-of-care ultrasound and a fast exam to look for both cardiac function and fluid in the abdominal cavity? Can I get labs, either point-of-care labs, hemoglobin or lactate, or labs actually from the clinical laboratory, CBCs, BMPs, or an SVO2. I'm also looking for my response to interventions. Again, in the acutely hypotensive patient, you're going to have made a decision to give some fluid, to start some vasopressors, to turn down that epidural. And that decision needs to be made acutely in response to the hypotension. But now you need to reevaluate. Has there been a response to my intervention? Has the mental status changed? What's the heart rate? What's the blood pressure and the urine output? The failure to respond to initial intervention should prompt consideration of transfer to the ICU.
As you look at these patients and you start to think about many of the hemodynamic changes that can occur after surgery. Not uncommonly, patients can become tachycardic. So what's your approach to working up a patient who's tachycardic after surgery, and maybe how does that differ from one who's hypotensive?
Certainly. So any patient who's had a surgical operation is at risk of having pain and analgesia. And so the first assessment I make is this patient tachycardic in response to their pain, both assessing their subjective response to pain and also if they've received appropriate analgesia. They're also at risk for bleeding. Every surgical patient who's hypotensive, or tachycardic should be evaluated for bleeding. Bleeding is a frequent complication of surgical operations, and the treatment for bleeding is stop the bleeding. That requires interventions such as ongoing surgery or a trip to the interventional radiology suite. And so evaluating a patient for bleeding when they're tachycardic, for example, by looking at their laboratories and going through the evaluation for hypotension, is critically important. Patients who are bleeding are not going to respond simply to resuscitation. You also have to consider the risk of an acute infection, for example, from an anastomotic leak, and then a primary cardiac condition, for example, a pulmonary embolus or an arrhythmia such as atrial fibrillation.
Let's pause there and talk specifically about the management of atrial fibrillation in the postoperative period. This is something that I think interns all over the world are getting called about all of the time. What's your approach to managing this very common condition?
So my first question when I encounter a patient with AFib, is this new onset AFib or is this chronic or paroxysmal AFib? A lot of the times you can get this data from the patient's history. If they've got a history of atrial fibrillation or if they've previously been on medications that suggest they have atrial fibrillation. The next thing I evaluate is their hemodynamics. If the patient is hypotensive and an atrial fibrillation, that's an emergency that requires an intervention. Once you've established that the patient is, for example, not hemodynamically unstable, and they have a new onset atrial fibrillation, then you can ask if this can be addressed with rate control, with beta block in a hemodynamically stable patient, or if you're going to try to chemically cardiovate this patient with something like amiodarone. If a patient is unstable, having a low blood pressure and an atrial fibrillation, that patient requires at least chemical cardioversion, if not electrical cardioversion. The last thing I think about with atrial fibrillation is that AFib is the tachycardic response of the patient who has a propensity for AFib. If the patient goes into a rapid ventricular response, that is their only way of mounting an increased heart rate and can also reflect pain or under resuscitation and may respond to a fluid bolus in the patient who is hemodynamically stable. In terms of anticoagulation, restarting anticoagulation depends on the surgery and has to be evaluated on a case-by-case basis. It's often safe to resume anticoagulation 3 to 5 days after non-neurologic surgery, but you really have to evaluate the patient's risk for bleeding and whether they can tolerate a therapeutic anticoagulation.
In addition to tachycardia and hypotension, one of the most common calls residents will receive for patients after surgery is for a patient with a fever. How do you think about a patient who's febrile after surgery, both in the initial postoperative period and patients who are a little bit further out from their operation?
So fever is a very non-specific response. It's generated by inflammation and cytokines that are produced in both response to tissue injury, but also in response to infection. In the immediate postoperative fever, it can be simply inflammation in response to the surgery. It can also be anesthetic complications, for example, malignant hyperthermia, which presents with high fever in the setting of hyperkalemia and acidosis. There also can be infections that predate the operation. These are rare and elective cases, and usually you can suss that out by reviewing the pre-op history, but can be more common in EGS or trauma cases. Late complications, more than, say, 72 hours after surgery, often reflect an infection that may be either independent of the operation or related to the operation. This can include respiratory infections like pneumonia, a urinary tract infection, a catheter or line-associated bloodstream infection, a wound infection, or an organ space infection, either related to the surgery or separate from the surgery.
As you point out, when you're going in to manage these patients, often you don't know exactly where the infection is coming from. What are your first steps in evaluating a patient who has an unidentified infection?
So again, the first step is to make sure that your patient is stable. When you're evaluating for a patient with an infection, you first want to evaluate, does this patient meet criteria for sepsis? Do they have signs of infection, but other signs of organ failure, such as altered mental status or hypotension? And if that's the case, you need to go down a separate path from evaluating merely the source of infection and evaluate for the patient's risk for sepsis. Once you've established that the patient is not acutely ill beyond their signs of infection, then you need to look for clinical source of that infection. For example, is there hypoxemia? Is there localized pain that can guide you towards the source of this infection? And do an objective workup that can include a urinalysis, a chest x-ray, blood cultures. And then both in the patients with fever and really in any patient, if a patient has an indwelling device, a catheter or a line, evaluate if that line can be safely removed as a source of the infection either present or in the future. Also consider imaging, both plain films such as chest x-rays and in the patient who is appropriate, a CT scan of the relevant body part.
Let's dive deeper into some of the common infections surgeons can encounter. What are your first steps to manage a patient with a soft tissue infection and a patient who has an organ space infection?
So the key to treating infections is to drain the infection, either by opening the overlying tissues or by placing a drain. You have to drain the source of infection, and then you need to treat with antibiotics. For skin and soft tissue infections, this often means opening the overlying tissue, both the skin and the subcutaneous tissue. So for a surgical site infection, you have to remove the skin closure and be sure that that entire space is completely drained. Infection that's in a closed space cannot be treated either by antibiotics or by the immune system, as neither the antibiotics nor the white blood cells can get to that space. You also need to debride any non-viable tissue. Again, this applies to a primary necrotizing soft tissue infection where you open the space and identify dead tissue and remove it. But also in a surgical site infection that's iatrogenic, you need to treat those similarly by opening the overlying tissue and debriding any non-viable tissue that can serve as a nidus for infection.
You've mentioned necrotizing soft tissue infections, which are obviously one of the most important diagnoses that a surgical resident should be able to identify rapidly. What physical and laboratory signs can be used to identify those patients?
Necrotizing soft tissue infections can be very difficult to diagnose clinically, in part because these infections track along tissue planes that can be deep to the skin, and so therefore do not always present with clear overlying skin signs of an infection. You look for pain out of proportion in a patient who has systemic signs of illness and suggestive laboratory investigations, elevated white blood cell count, elevated glucose, elevated CRP, and electrolyte abnormalities, specifically decreased sodium levels. There is the Leinert score, which is commonly discussed, but should be really used with caution. The original study for the Leinert score used approximately 100 patients and performed a multivariable regression to identify factors that correlate with the patient having a necrotizing soft tissue infection. That study was done over 20 years ago, and it's unclear to me that those data hold up over time. In follow-up analysis, it is somewhat sensitive, so patients who have a necrotizing soft tissue infection will likely have a high Leinert score. However, it's not very specific. It's really a general score of infection. So you need to lean back on your clinical assessment, evaluating the patient, if the patient's pain, if they have an appropriate history, a risk of either immune dysfunction or a overlying injury that could serve as a nidus for the infection, and then also imaging. Imaging is important to see if there is either evidence of gas in the soft tissues or evidence of fluid. For me, evidence of gas or fluid in the soft tissues combined with pain in a patient who has clinical signs of infection should lead to an aggressive evaluation for a necrotizing soft tissue infection, which may include an operation to drain that infection.
As we're talking about infections, we find that a lot of our surgical patients are prescribed antibiotics. What data do we have about the need for antibiotics in surgical patients and the duration of these antibiotics after surgery or after management of an infection?
I think the best data that are currently out there come from the STOP-IT trial. The STOP-IT trial was a pragmatic randomized controlled trial looking at patients with intra-abdominal infections. This is important because the pragmatic trial has a control arm, which is usual care. And so that encompasses all of the things that we do as clinicians. We follow white blood cell count, we follow fever, we follow clinical course, we worry about the nature of our infection. In the treatment group, they randomized the patients to 4 days of empiric antibiotic therapy. These patients were enrolled when they were identified as having an intra-abdominal infection, and the start date of the antibiotics was once the infection had been appropriately drained as decided by the interventionalist. So if IR placed the drain, they said they had completely drained the infection. And if the surgeon went back to the operating room, the surgeon said that they'd completely drained the infection. The patients then received either 4 days of empiric antibiotic therapy or usual care. There was no difference in outcomes in the patients who received 4 days of empiric antibiotic therapy versus those that received usual care. In the usual care arm, patients received 8 days of antibiotic therapy, twice that of the treatment arm, suggesting that usual care was using more antibiotics than were needed to adequately treat the patient. I think these are very, very strong data, given that it was both a pragmatic study design, controlling for the variance in practice pattern among interventionalists, and also providing a discrete starting point, that is, once the intervention had been drained, again, as judged by the interventionalist. This incorporated both expertise of the clinicians taking care of the patients and a very well-defined endpoint for the antibiotics.
Dr. Turnbull, thank you so much for being with us today. I think we got through a ton of great information about common postoperative problems. As always, if you're looking to learn more, you can check out some of the literature we referenced in today's episode in the show notes, and a full review of common postoperative problems can be found in the Washington Manual of Surgery.
We are Drs. Paul Wise
and Jeff Blatnick,
senior editors of the Washington Manual of Surgery. We'd like to thank the residents and faculty of the Department of Surgery at Washington University Medicine, and we'd especially like to thank our associate editors for this edition, Drs. Katharine Caldwell, Ina Chen, Bradley Kushner, Martha Bucky McGilvray, and Jorge Zarate Rodriguez.
We hope that you enjoyed this episode of the Washington Manual of Surgery podcast. For more comprehensive information in a brief outline format, check out the print and digital version of the Washington Manual of Surgery, published by Wolters Kluwer Health and Lippincott Williams & Wilkins. Please search online for the Washington Manual of Surgery 9th edition to purchase your copy of the manual.
To learn more about the educational opportunities available in the Department of Surgery, please search General Surgery Residency at Washington University School of Medicine in St. Louis.